Welcome, everybody. And today we're going to be talking about pulmonary issues in older adults. I'm Donald Jurovich. Many of you may have heard me speak before. If not, and you're new to this, I'm a professor of geriatrics at the University of North Dakota. So we can have the next slide, please. So the goals today are to report on age changes in lung function. And then we want to explain how age alters lung resiliency, that ability to bounce back, if you will. And then we want to look at the question of common pulmonary conditions as we get older. Next slide. Here's a case report, 88-year-old lady who complains of dry cough for the past month. There's no fever, chills, or night sweats. She uses 2 pillows while sleeping. She has hypertension, pre-diabetic, mild cognitive impairment, seasonal allergies, and hypothyroidism. She lives alone, does not smoke. She has a glass of wine each night while watching TV. And on exam, there is decreased gag reflex, and wheezing is heard on the right side of the chest. Her pulse oximeter is 95% on room air. Next slide, please. So what do you think is going on here? And you can put in the chat if you wish. I'll take a peek here. And anybody want to venture a guess as to what might be going on with this lady with her cough that's been going on for a little while? And the wheezing.
Okay, so chat was disabled, I just noticed, but it is enabled now.
Yeah, it's enabled. Very good. Okay, yeah, so you can type your answers in. Yeah, so some aspect of the wine. So certainly you could consider allergic reactions to the sulfas in the wine, perhaps. I like Lindsay's comment about aspirating. I think that would be a good thought. And the clue there was the decrease in the gag reflex. So the other element that we might want to consider is that, and again, everybody's thinking the right way, is that the wine can decrease the esophageal sphincter tone and thereby creating reflux esophagitis, which can also, with reflux, cause regurgitation, particularly at bedtime, and causing silent aspiration. So good. I think you guys had some good thoughts here. All right, next slide, please, Gunjan. So let's talk about the aging lung. So we know that overall the airway sizes are reduced with time, and that those alveolar sacs that exchange oxygen and CO2, that those become shallower, and the lung itself is less elastic, so it becomes less compliant. And perhaps most importantly, then we don't always think about this clinically, is that the diaphragm strength declines with age. And so we know overall that there's 1% lean mass or lean muscle decline per year after the age of 60. And so too, the internal muscles of the smooth and skeletal muscles that are internally, they also go through a declination in strength. So that's really important, and we'll see later why it's always useful to have people do deep breathing exercises and core training, because those are all helpful for improving diaphragm strength. Next slide, please. So the question of resiliency is the ability to bounce back from injury. And so we know that lungs have to recover and should recover from infections, whether it be COVID, influenza, even respiratory syncytial virus. We know that in young individuals that the inflammation comes and goes, whereas with the older adult, you can see a whole list of inflammatory molecules that get activated and they persist. And as they persist, they create low-grade inflammation or maybe even high-grade inflammation. A lot of this leading to pulmonary fibrosis and predisposing the older adult to increased morbidity, problems, and mortality. And so one of the reasons why there's a 25% chance of death from COVID in a 90-year-old is precisely because of this mechanism. So the lungs get infected, they don't recover, and there's persistent inflammation that sometimes people call it a cytokine storm, that there's like a thunderstorm just blasting all these inflammatory molecules and they just can't shut off. Next slide, please. So we can see that lung function can be measured by different measurements. One is called vital capacity. And you can see there with normal aging that there's the dark line there where there's a steady decline in vital capacity. What's not showing on this slide is that there are some younger people in their 50s who may have the lung function of a 100-year-old. And you can guess what might cause that loss of lung function as a 50-year-old. And if your first thought was smoking, that would be the correct answer. Next slide, please. And you can see another lung function, forced expiratory volume in 1 second, declines after the age of 20. But look at the range, those dots go up and down. So you've got some people who are 80, and if you look at that dot right up at the top, that data point right at the top, they actually have the lung of a 40-year-old if you just track over. And then likewise, if you look at the 40-year-olds, they have an FEV1 down at the bottom there, those bottom spots, and they are equivalent to what a 60-year-old might have. And so it's a very important concept that as we age, not all of us look the same way in terms of our physiology. And there's things that we can do to influence the lung performance, such as avoiding secondhand smoke. I just noted in the newspaper that our new leadership in Congress has, in their infinite wisdom, has decided to reintroduce smoking privileges in the congressional offices. And good gravy, all those poor congressional interns that have to be exposed to secondhand smoke, thus increasing their exposure to chronic lung disease and to cancer, lung cancer. And so it just really gives you pause for consideration as what the heck is going on in the minds of some of our representatives. Next slide, please. So one of the problems that occurs is this alveolar arterial mismatch. So that what that means is that the oxygen that's getting into the lung doesn't really match up well with the arteries in the lung just can't absorb all of the oxygen. And that's a lot. There's a variety of reasons for that happening, but you can see that somebody that's in a hospital bed in a reclined position, that gradient, that arterial alveolar mismatch is made even worse. And so the lying position is not a good one for older adults is what I want to emphasize. Next slide, please. The other thing that we want to consider is what we call primary and secondary prevention of pulmonary changes with age. So primary prevention would be, for instance, smoke avoidance. The story I gave you about the congressional offices allowing smoking. That's a disruption of primary prevention. You don't want to be exposed to smoke. You don't want to be exposed to particulate matter. And then an example of, secondary prevention is where you have somebody that has smoked, has lung disease, then you want to have them try to recover from their lung function, either going through pulmonary rehab. A lot of COVID, post-COVID, long haul COVID patients are going through pulmonary rehab. And the secondary prevention in that case is to stop smoking. And what's illustrated in this particular graph, again, there's a lung function on the left there called FEV1 relative to age. And you can see that if the smoker stops with that upper orange graph there, that they can actually recover a lot of lung function. So that's the important consideration, that no matter what age you stop smoking, you will be able to recover substantial lung function. So that's called secondary prevention. Next slide, please. So another primary prevention is, in addition to smoke avoidance, is vaccination. And so the current recommendation now is pneumococcal, pneumococcal 15, followed by the 23-valent, or to start off with the polyvalent pneumococcal vaccine of 20. And usually that should be given after the age of 65 as a one-time dose, or the age of 55 with multiple chronic conditions such as diabetes and COPD. The other recommendation for lung function is to give the what's called the high dose or Fluzone vaccine. It gives some incremental benefits for protecting against influenza. And it's important to realize that the young old, those that are in their 65 to 75-year-old, can develop a pretty robust response to the influenza vaccine. But as we get older, between 80 and 90, it goes down to one out of 10 actually get a adequate benefit, from the influenza. Now, that doesn't mean not to get the influenza vaccine if you're 90 years old. It just means that the likelihood of the vaccine giving you optimal protection as when you were younger is considerably less. And then I've got a yellow asterisk there. You go 50% reduction in Alzheimer's disease. Well, that's the news. It's been published that people who get regular vaccinations have a 50% less likelihood of getting Alzheimer's disease. And that information is something that I share with my patients, because I ask them, do you want to get Alzheimer's disease? And they go, no way, no how. And they say, well, people that get vaccinated regularly don't get Alzheimer's. No, it's a little bit of an overstatement, but I think it's an important point of view to share with our vaccine hesitant patients. Next slide, please. So just to introduce you to some terms here, the medical term of Tachypnea is the rapid breathing rate. And if you see that in the older adult, if they're breathing really fast, they're in big trouble. Because what happens is that the carbon dioxide sensory, as well as the oxygen sensories in the aging body, are less sensitive. And so once they get activated, that means that they've been pretty far off from normal. Another consideration, a fast heart rate or tachycardia may actually represent pulmonary disease. And so it may represent deconditioning. But when I see a geriatric patient or an older adult in my clinic, I often will walk with them with a pulse oximeter to see if their oxygen goes down while they're walking, and or to see if their heart rate goes up dramatically after just a few lengths down the clinic hallway. Because if only walking 20 to 50 feet suddenly starts causing a rapid heart rate, it's going to be a pretty good indicator that they're either deconditioned or they may have a oxygen problem or heart failure. Next slide, please. So when I listen to the lungs, I always have the patient take a really deep breath and let it out fast. And that's a forced expiration. And a lot of times that'll pick up wheezing that you wouldn't hear normally. I'd already mentioned about the 50-foot pulse oximetry test. So that's where you have somebody take a pulse oximeter on their finger and you test while they're resting, and then you have them walk a distance. And generally, if people are going to desaturate and have a lower oxygen level, it'll occur within just a few steps. You'll start seeing that their oxygen will go down, heart rate starts going up, and you know that there's some underlying pulmonary function problem there. Next slide, please. So what about chronic coughs in older adults? So this could be due to a variety of symptoms. I would point to the third issue here, which is what we talked about with the case report in the beginning of nocturnal regurgitation or GERD. And that can cause habitual, coughing and wheezing. So first line of action there is to prescribe proton pump inhibitors to see if you can reduce the incidence, and also to elevate the head of the bed, and then to also do things that we alluded to, which is reducing alcohol intake and avoiding foods that can cause regurgitation. Asthma can be a sign of a chronic, or chronic cough can be a sign of asthma in the older adult. And again, sometimes the asthma is kind of a cult, it comes and goes, and you don't always hear it when you're in the clinic. The big one is postnasal drip. So older adults can and do get allergies late in life, and they're the same varmints that we all are concerned about with airborne allergens, scents, and perfumes. And I often have individuals consider going to a perfume-free laundry detergent as a first step. Medications, 1 out of 10 individuals on ACE inhibitors, such as lisinopril, can lead to a cough, and that cough can show up at any time. So, well, I've been taking this medicine for 5 years. I never had a cough. Well, you know what? There's no rhyme or reason as to when that cough shows up. Congestive heart failure can be another reason for coughing, and then infection. So the pertussis, a persistent cough sometimes is due to chronic mycoplasm. Excuse me. And we also need to consider tuberculosis, reactivation TB. I didn't put that down there, but the most prevalent occurrence of TB occurs in the older adult. And nowadays it's seen more in new Americans and refugees. And then interstitial lung disease, which can be idiopathic, like nobody knows how they got the lung disease, or it could be due to occupational exposure, including asbestosis. And then tumors can cause coughing. So pretty long list. The shortness of breath as a symptom is basically the same list that we just talked about. And then with the added caveat that if there's a intermittent fevers or night sweats, think about tuberculosis. Next slide, please. In shortness of breath, we need to consider whether when somebody walks for a distance and then gets short-winded, whether that's associated with CAD or coronary artery disease. And sometimes this is more prevalent in women than in men, where they say, I just can't catch my breath. Well, that might be a good time to do a stress echo test. The other reasons that you can get shortness of breath can be due to what I mentioned earlier, was deconditioning, but you also have to think about anemia. And typically the anemia has to be pretty severe. It has to be 7 grams of hemoglobin or less to really start causing that shortness of breath. And then also asthma can cause particularly cold-induced asthma. Now that we're in the cold weather, there might be a lot of asthma going on. In terms of the additional thoughts about shortness of breath, when you get that description by the patient of a tightness, that usually represents an asthmatic version of dyspnea or shortness of breath. Whereas if they describe something that feels like heaviness, that could definitely be a cardiac etiology related to heart failure and, again, coronary artery disease. So little subtleties in how they talk about their sensation of being short of breath can help guide you in thinking about what the underlying cause of it might be. Next slide. All right, so I want to move to upper airway issues. So same incidence in older adults as younger populations. And so we can see here a CAT scan on the right there with, actually, if you look at the right side of that, that represents the left sinus, and you can see air fluid levels. So that's an acute sinusitis, that opacity, on the side there. You can also see that the nose has a little nasal septal deviation. So there's that white line going through the middle there of the nose is crooked, representing a displaced septum. But anyways, we want to classify these conditions as either acute, subacute, or chronic. So after 3 to 4 months, it's likely to be chronic. Next slide, please. So people will always come into my clinic and say, I've got sinusitis, I need antibiotics. And chances are it's not that. It could be congestion and pressure, but it's not always sinusitis. And the diagnosis of that includes purulence or pus, fever, in addition to the pain and pressure. So pain and pressure alone is not an indication of bacterial sinusitis. I mean, there could be other causes of sinusitis, such as congestion and viral, an upper viral tract infection. But basically, the intervention involves saline and irrigation. A neti pot is what we call it, and pain control, usually through Tylenol. Compresses, I didn't list that, but cold or warm compresses. And then if it doesn't go away after 7 days, or the symptoms really start to escalate with additional fever or even chills, then antibiotics are indicated. Next slide, please. Yeah, and I just want to emphasize that the vast majority of sinus issues are viral. And here's some of the recommendations for dealing with viral sinusitis. And then, using eucalyptus and menthol, for helping open up the nasal passages. As an osteopathic trained doctor, there's actually some techniques that you can use to help open up the nasal passages, such as stimulating the nasal nerve along the sides of the nostrils and down towards the edges of the mouth. And so just a simple couple-minute massage in that area. And then above the eyes. And then the second way is to tap on above and below the eyes as another way to mobilize fluids. I didn't mention here steam therapy would be another one, and also the neti pots also can be helpful. Okay, next slide. So in terms of chronic sinusitis, the mainstay is to use topical steroids to try and open up the nasal passages, and also to create a anti-allergen or an allergen-free environment. Try to avoid Benadryl. It has diphenhydramine in it, which predisposes older adults to delirium. So you usually use the Claritin and the second generation antihistamines. I recommend a bedroom air filter, in addition to, if somebody already has a forced air furnace with a filter, you would be amazed at how much it doesn't filter out. And so having a bedroom air filter is useful. In the cold months here in particular, the humidity goes down to 10 to 20%, and you should need to bring the humidity up closer to 25 to 30%. And so I recommend that folks get a humidity detector from Home Depot or wherever, and just monitor the room humidity and make sure that they maintain it at as close to 30% as possible. I also recommend avoidance of scented products. It turns out that some makeup has nickel in it, and that in itself can be an allergen, which is kind of interesting. I don't know how much, but it is reported that some of the makeup can be allergenic. And then also to consider the environmental checks, such as pet dander and mold, which can be a big one. Next slide, please. So in terms of late onset asthma, it affects about up to 10% of older adults. And it's a big factor in asthma-related deaths. So it's a big deal in the older adult population. There's a higher mortality than younger populations, probably because of all the things we talked about earlier about how the lungs change with age and predisposes the older adult to being tipped over into a more catastrophic moment when the lungs close up, the bronchial airways closed. Next slide, please. So some of the aspects of late onset asthma or the factors that drive it are smoking, new onset of snoring, if you have rhinitis or nasal congestion and postnasal drip, chronic sinus issues, weight gain and obesity. All these are factors that can predispose you to asthma occurring late in life, and these are people that never had asthma before. They just, 70-year-old comes in and they've got wheezing. I don't know where that wheezing came from. That's late onset asthma. Next slide, please. So some of the triggers often are, now I said almost exclusively when I see patients, it's because they were exposed to some sort of virus. They were taking care of their grandkids, or they went out to a concert and they came back either with COVID or influenza, and then all of a sudden they're wheezing, and that's the story. Sometimes they are exposed to environmental fumes, such as cleaning agents, again, perfumes, scents, and then also ambient particulate matter. And it was kind of interesting. One of my patients last week was saying, "Oh man, it's just like I've got this breathing problem," and she was wheezing. And my geriatric fellow said, "Well, that we're in the red zone for air quality in Fargo, where I had my clinical practice." And I said, "I've never heard of that, that there's like bad air in North Dakota." So he shows me the EPA, the Environmental Protection Agency. It shows me the graph, the climate change. And sure enough, we were in an inversion in a big red zone around Fargo, which was migrating through the Red River Valley. Apparently that was on the news. I don't always listen to the news, so my wife chastised me. She says, "Well, didn't you know there was an inversion?" And I go, "No, I didn't." But that was a very clear example of where the inversion had caused particulate matter to increase, and for people that are sensitive to it, started to wheeze. Next slide. So the diagnosis of late onset asthma is the description of chest tightness as opposed to heaviness. Remember that difference, that there is either they can hear the wheezing or you can hear the wheezing on exam. It may occur just at night. They will have feelings of shortness of breath, and they may have a cough. We know that the lung functions on the right column there with the forced expiratory volume versus the vital capacity, the ratio, not the ration, sorry about the spelling, decreases with aging. For physicians in the audience, we no longer do the methacholamine challenge. And there might be some, when I would say more cutting edge evaluations with nitric oxide exhalation, but those tend to be a little not done on a regular basis. Okay, so some of the challenges with treating late onset asthma are most clearly dementia. Patients that are cognitively impaired don't always remember to take their inhalers. COPD is a progressive disease, and it doesn't always respond to the inhalers. Persistent tobacco use is its own can of worms. And then also the problems that are compounded by obesity. In terms of the physiology, the biggest problem is, the airways are not pliable anymore. And so even though you give the inhalers, they don't do as good of a job as they would with a younger patient because the airways are less compliant and less able to open up. The other problem is that the older adult may not really think that they're short of breath, and you'll be talking to them and they'll be, kind of huffing and puffing, and you go, "Are you short of breath?" And they go, No problem." Yeah, you go, "All right," but they got a respiratory rate of 20, so that's there's something going on. Okay, next slide, please. So we don't know exactly whether allergies are linked to this late onset asthma. A lot of people say, "Oh, you got allergies." Yeah, it could be, but it may be, and I don't know the exact distribution, but not everybody has that. One of the things to consider, and this is sort of a little bit controversial, but if you're on beta blockers for either blood pressure or coronary artery disease, or for other reasons, like propranolol is given for essential tremors, and in particular, propranolol may be the culprit that's causing wheezing. The other beta blockers maybe not so much because they're not as they don't get distributed into the lungs as much. But the point is that if you're on beta blockers and you're an asthmatic, it may blunt the response to epinephrine if you got into an anaphylactic situation. So smoke exposure, and that could be fireplace exposure. It could be, cigarettes, cigar smoking, pipe smoking. I have to share with you. There's a pickup truck that goes around in Grand Forks that goes around the park that has a little scent of marijuana going around as I'm cross country skiing. So I always know when the truck is coming by. Here the last couple of days I've noticed, and I started giving a coughing spell there. Personal anecdote. But then the other consideration in terms of asthma is that you might have somebody that's aspirin sensitive, and that's actually called Sampner syndrome. It's a well-known syndrome where people get asthma-like symptoms while they're on aspirin, no matter whether it's baby aspirin or more. And they also, if you look on the exam, they have polyps inside their turbinates on their nose. Next slide, please. So just some issues about how to manage asthma. The biggest thing is just to make sure that they're taking the inhaler properly. And so I almost automatically prescribe a spacer. It's a little cardboard space that they put over the inhaler, and that helps get more of the medication into their lungs. Next slide, please. So basically, just this may be a little too deep of a dive here, but the rescue inhalers are the albuterol, the alupents. They're called beta-2 agonists. In terms of a lot of COPD is treated with the inhaled anticholinergics. These are called ipratropium, maybe known as Comavent. And again, it's not quite as clear that they're as effective in asthma as the beta-2 agonists. The limiting features about all these inhaled medications are cognitive impairment, and particularly with the anticholinergics, you can get urinary obstruction. Inhaled corticosteroids are also part of the asthma regimen. So basically the top line and the bottom line there are the mainstays for asthma treatment. Next slide, please. There's a whole host of new agents that can be used. So if you're having difficulties regulating, there are this list. I'm not going to belabor all these different compounds, but good news in a sense that they're coming out with new products. They don't necessarily work tremendously better, because of the aging lung, but they are options when the two mainstays of steroids and beta agonists don't work. Next slide, please. So moving into from asthma into COPD, we've got two forms of it seen here, the emphysema and bronchitis. Next slide. So chronic lung or chronic obstructive pulmonary disease has a pretty high prevalence as chronic conditions. It's one of the leading causes of hospitalization, right behind heart failure. And the somewhat bad or unfortunate news is that if you end up in the ICU, there's a pretty high mortality, both either in hospital and out of the hospital. Next slide, please. So the COPD diagnosis involves an array of symptoms, particularly cough. They may have wheezing on their exam. And if you do have them take a really deep breath and let it out as fast as they can, and you count to 9 seconds to get all that air out, that's another strong indicator that they have COPD. Next slide, please. There are staging for COPD, and they're called the GOLD classification. So these are the global lung disease classifications, and they're based upon pulmonary function tests. Just suffice it to say that when we establish GOLD level 3 or GOLD level 4, we're starting to get into the point of lung function, particularly with GOLD level 4, where we need to talk about comfort care rather than curative care, i.e. palliation and hospice. Next slide, please. So this is just a quick list of how chronic obstructive lung disease is treated. I don't want to get too much in this, but again, we just need to consider the main points of primary and secondary interventions, which is the vaccinations, and then there's you start off with short-acting bronchodilators, and then you eventually move to long-acting bronchodilators is the bottom line. Okay, and then I'm sorry, in the last point there in the GOLD stage 4, that's basically when people start using oxygen. Okay, next slide. There are some treatments, for COPD that doesn't respond to the usual treatment regimen. One of the tricks here that I think is interesting is that third point of having a fan in the room. It helps in a psychological sense that for patients that have air hunger. But ultimately, people that are gasping for air from their COPD, morphine would be a reasonable intervention. Next slide, please. In terms of the oxygen, the point of getting oxygen is when they have an oxygen level less than 55 millimeters per mercury. So that's generally found on a blood test. And then basically 15 hours daily will help increase survival and overall cognition. Not everybody likes to wear their oxygen, so that's why they say 15 hours. This is just a reminder that lung function can improve. I showed a slide earlier, and just really, this was done as a British study quite a while ago. And what they did is they took these 55-year-olds and they said, "You, sir, you Mr. 55-year-old smoker, you have the lungs of an 85-year-old. Stop smoking." And they had much more success by showing them their lung function than wagging their finger at them and saying, "You must stop smoking." So it's one of the cases where shaming people with bad aging function at a younger age really does make a difference in their compliance with smoking cessation. Next slide, please. So that leads to the whole question of how to stop smoking. The first one is to just screen for whether people use nicotine, and then to get their understanding about their readiness to stop smoking, and then to make referrals to programs as well as offering medications. There's a lot of smoking cessation clinics that really focus on that. And The last point here is a recommendation to arrange a quit date. And I'm not sure I agree with arranging a quit date. I think generally the experience is that when people stop smoking, they just make up their own mind to do it and they don't let anybody know. So announcing that I'm going to quit on January 20th, 2023 has a high likelihood that that person's not going to stop smoking. They just generally, the ones that are stop smoking are, like I say, just they don't announce it, they just do it. Next slide, please. Some of the other things about lung disease is to really be mindful that when they have these coughing spells and wheezing spells, that they don't automatically go on antibiotics, because I can't tell you how many times we've treated Clostridium difficile colitis, which can be a death knell. Some people die from this colitis, and it's antibiotic induced. Importantly, the anemia doesn't influence, the performance. We used to think that keep the hemoglobin above 10. Now it's more above 8. And again, it's doesn't really have a strong correlation. And then oral steroids is often, with a COPD exacerbation, people get put on high dose oral steroids. And that's short term and that works, but only very few need it long term, but keep it in mind. I put down harmonica therapy for anybody that deals with COPDers. University of Michigan study says that playing the harmonica is as good as pulmonary rehab. Next slide, please. Yeah, and then considering palliative care. So those are individuals that you just can't treat adequately. They end up in the emergency room time and time again. Oxygen, they don't respond to the oxygen. They start to lose weight, and they become frail. So those are all indicators when hospice and palliative care makes sense. Next slide, please. So idiopathic pulmonary fibrosis is kind of a weird disease. Nobody knows how this comes about, but you'll, on physical exam, you may hear crackles, like if you sort of wrinkle your hair next to your ear, those are called crackles. And these individuals have, they complain of fatigue, they have a dry cough. Next slide, please. So the treatment is, for idiopathic pulmonary fibrosis is steroid therapy, so prednisone or pirfenidone. And also if they have underlying pulmonary hypertension, you can use Viagra at low dose. And then there's I put down anti-senescent cell treatment. There's some new studies indicating that monoclonal antibodies with some plant medicinals in combination might stabilize pulmonary fibrosis, to be determined. Ultimately, these folks, when they progress, would require lung transplantation. Next slide, please. This is a big one. OSA, if you see it in the chart, OSA means obstructive sleep apnea. So it's pretty prevalent. The 30% of the population that's obese here in North Dakota and elsewhere are at risk for OSA. In addition to medications, chronic alcohol consumption, and upper airway anatomy, where you have a thick neck. Next slide, please. So the untreated obstructive sleep apnea increases the risk for myocardial infarction, stroke, and those folks have 3 times the mortality as a cause of that, or as a reason for that. Next slide, please. So daytime somnolence could be a good clue if somebody screens. So this is one of the reasons why we do the geriatric 4Ms and why we screen for cognitive impairment. Because if somebody screens positive, you start thinking, well, I wonder if they have obstructive sleep apnea as an underlying cause for their memory loss. Frequent napping, and a big one is falling asleep while driving. And I've been a medical consultant on a couple of cases where older adults fell asleep at the wheel and crashed into people, causing deaths, and not a good thing. Next slide, please. So some of the sleep apnea clues are snoring and or observed apnea. So if you see somebody stop breathing for 5 to 10 seconds, that could be an indication that they have apnea. Next slide, please. So the treatment of sleep apnea includes elevated head of the bed by about 20 degrees, or to sleep on your side. Weight loss is important, and then being evaluated in a sleep lab and getting a prescription for CPAP. Also, as a caveat, is to avoid alcohol, and ask people if they take Tylenol PM, because sometimes people take that because it has Benadryl, and Benadryl makes them sleepy, and that's not too good. Next slide, please. I wanted to bring up this whole issue of atypical presentations of disease. So if somebody has pneumonia and they're an older adult, they may present with confusional state or delirium, or they may say, I've got pain in my belly, this diffuse pain. And that actually is representative of community-acquired pneumonia. It's abdominal pain, when expressed in the emergency room, often takes doctors down the wrong. It's a rabbit hole, because the pain may actually be reflective of lung problems. Next slide, please. So all of these viral infections, whether it be COVID, influenza, respiratory syncytial virus, is represented by these different x-rays, that there's a high mortality that's associated with it. As the older you get, the more likely you're going to pass away, from these respiratory infections. So that's why masking up and, trying to prevent these old folks from getting viral infections in particular is so critical. Next slide, please. So just to summarize and then open up to some comments and questions, we know that the aging lung function changes. It predisposes, we didn't use the term atelectasis, but that's where the collapse of the lungs occur, and that's why we encourage deep breathing exercises. Always remember to vaccinate, and it's just using the Alzheimer's, avoid Alzheimer's, get vaccinated. I don't know, whatever methodology you have to encourage people to get their vaccines, I think is good. And I'm still a big advocate of masking in public. I know we've relaxed all of this, but it's a one moment exposure to a 90-year-old, and that may be their last experience here on Earth. So I try to be very aggressive with mask wearing, and I encourage my patients when they come in, and a lot of them don't wear masks, because they're not required to. They don't have symptoms. But I said, you might, there might be that pediatric case or somebody, a kid coming by and just, starts coughing up a storm, and then you're exposed. So it doesn't hurt, at least when you're indoors.